Today we are discussing the Porphyrias. My name is Danja Schulenburg-Brand and I'm a chemical pathologist working in the Cardiff Porphyria Centre in the United Kingdom. As part of the discussion, we'll discuss the heme synthesis pathway. We'll look at the different types of porphyria. We will look at the diagnostic laboratory approach to the acute and cutaneous porphyrias, and also the appropriate sample types. And I will show a few example cases. This is the heme biosynthesis pathway, which starts with an amino acid glycine and a metabolite of intermediary metabolism, which are converted to various different porphyrin precursors, which are then sequentially converted to the different porphyrins. The final step being incorporation of iron into protoporphyrin to produce heme. Aminolevulinic acid, ALA, porphobilinogen, PBG, uroporphyrin and coproporphyrin are water-soluble, so we're able to measure them in the urine. Coproporphyrin is also fat-soluble, as is protoporphyrin, and so we can measure these in the feces. We're also able to measure the porphyrins in the plasma and in erythrocytes. The analysis of the porphyrins and porphyrin precursors are dependent on certain physicochemical characteristics. Most laboratories uses porphobilinogen's ability to form a magenta-colored product with Ehrlich's reagent, which can then be measured spectrophotometrically. ALA is converted to PBG and then measured in the same way. The porphyrins have a very specific absorption spectrum with an absorption maximum around 400 nanometers, the so-called Surrey band. The porphyrins, once absorbing light, also fluoresce at very specific wavelengths of between about 615 to 632, 34 nanometers. And it's these two characteristics which enable either spectrophotometric or fluorometric analysis. These are the porphyrias. There are 8 different conditions, and different conditions manifest depending on the deficient enzyme. One porphyria results due to a gain of function mutation, and this is X-linked erythropoietic protoporphyria. The porphyrias in the red boxes are the porphyrias that present with acute neurovisceral crises. The other porphyrias present with skin manifestations, but hereditary coproporphyria and variegate porphyria can present with both. Of the acute hepatic porphyrias, acute intermittent porphyria, AIP, hereditary coproporphyria, HCP, and variegate porphyria, or VP, are the most common. In the United Kingdom, AIP is the most common, with a symptomatic prevalence of approximately 1 in 180,000. And this is the porphyria that presents only with acute neurovisceral attacks. HCP and VP can present with either acute attacks or skin lesions, or both. Acute neurovisceral attacks, or acute attacks of porphyria, occur predominantly in females at a ratio of 4:1. And this is mostly a disease of young females in their 20s, 30s, and sometimes 40s. It is very rare to occur before puberty and very unusual to have acute attacks postmenopausally. The clinical features include abdominal pain that gradually worsens and becomes very severe. Patients can also have pain in other areas of their body, such as their back or legs, for example. And this is usually associated with increasing nausea and eventually vomiting. They can also have other autonomic features, such as urinary retention, constipation, and cardiac features. They can become profoundly hyponatremic. Patients can also develop seizures and present with other central nervous system problems, such as psychiatric symptoms, which can include sleeplessness, anxiety, but also psychoses. This can be a very severe condition, and acute attacks can be life-threatening because patients can develop muscle weakness, which initially is mild, but it can progress to paralysis requiring intubation and ventilation. The precipitants of acute neurovisceral attacks are hormones, such as progesterone, and many prescription medications, also illicit drugs, excessive alcohol drinking, smoking, severe infections, stress, and severe dieting in the form of carbohydrate restriction. And we think that it's the porphyrin precursors which are toxic, probably aminolevulinic acid, which then cause neuronal damage and affect the central nervous system, the autonomic nervous system, and the peripheral nervous system, causing the symptoms. So this is the heme biosynthesis pathway depicted in a slightly different way. It's important to note that heme has an inhibitory effect on ALA synthase. So ALA synthase, the first enzyme in the pathway, is the rate-limiting enzyme. Now, the triggers described on the previous slide, either through decreasing heme, indirectly or directly stimulate ALA synthase, which then switches the pathway on. In the case of AIP, there's a primary block in the pathway at the level of PBG deaminase, and therefore the toxic precursors PBG and ALA accumulate. In the case of VP and HCP, the the porphyrin metabolites, which accumulate in those conditions, secondarily inhibit PBG deaminase with the same consequence. So the treatment involves initially to firstly remove or treat the precipitant, such as removing the unsafe drug that the patient was started on, and then to provide symptomatic relief using medications only from our safe drug list. In the United Kingdom, we have a safe drug list that we provide our patients and which is updated every year. The patients usually require high doses of opiates, as this is a very, very painful condition, but other symptomatic relief such as antiemetics is usually also required. If patients cannot take tolerate oral fluids and require intravenous fluids, then after resuscitation, we advise giving saline together with dextrose and to avoid dextrose on its own due to the hyponatremia risk. If the attack is severe or the attack progresses, or there is red flag symptoms such as hyponatremia or neurological features, then we use a specific treatment, hemarginate, and that's given intravenously daily over 4 days or for 4 days. And this treatment, hemarginate, inhibits ALA synthase and therefore inhibits the pathway and treats an acute attack. And the prognosis of an acute attack is good. Even with profound motor neuropathy, patients can recover, although it might take some time. Long term, we counsel patients to avoid the known triggers and to always carry their safe drug lists with them to ensure that if anything new is being prescribed, it's checked against the safe drug list. And this is available through the Welsh Medicines Information Centre. And I've put a link there so that anyone is able to access that. We also counsel patients to avoid excessive drinking, fasting, and to treat infections promptly. Now, once someone has a biochemical diagnosis of an acute hepatic porphyria, we usually do the genetics. And this is to identify the pathogenic family mutation so that relatives at risk can also be tested. Although the penetrance of the acute hepatic porphyrias are low, family members who inherit the pathogenic family mutations are at risk, and we avoid them or counsel them to also avoid the known triggers to prevent ever having or to prevent or to decrease the risk of developing acute neurovisceral attacks in future. For people who are very severely affected and who've developed recurrent acute attacks, who is the vast minority of the patient group, there is a licensed preventative therapy available, givosiran, which is an RNA inhibitory molecule inhibiting RNA synthesis of ALA synthase. And this treatment is very efficacious in preventing acute attacks of porphyria. So in the laboratory, our approach is that if someone has symptoms that is thought to be due to an acute attack of porphyria, we ask for a urine sample first and we do a urine porphobilinogen. Because if the sample was collected at the time of the patient's having symptoms and those symptoms are due to an acute attack of porphyria, then the urine porphobilinogen should be significantly elevated. The second step, once the acute attack has been confirmed biochemically, is then to identify the type of porphyria. And this is done by analyzing the plasma. If the plasma fluorescence emission peak is at a position greater than 624 nanometers, then that's consistent with variegate porphyria. If the plasma peak is less than 623 nanometers, or there isn't a peak, then it could be either be AIP or HCP. And then a stool sample is required. But we fractionate the porphyrins by using HPLC, and we identify the copper porphyrin 1 and 3 isomer, and we work out the ratio. And if the copper porphyrin 3:1 isomer ratio is less than 1.4, which is normal, then that's consistent with acute intermittent porphyria. If the fecal copper porphyrin isomer ratio is greater than 1.4, then that is diagnostic of hereditary copper porphyria. So to screen for an active acute porphyria, a urine sample analyzed for a urine porphobilinogen is the most appropriate sample, and it needs to be protected from light after collection, because the treatment of an acute attack initially is the same, independent of the type of porphyria. So the most important step is to diagnose or to confirm the acute attack that is clinically suspected, and the type of porphyria can be identified at a later stage. So this is an example case. A 34-year-old female presented to hospital with severe increasing abdominal pain over several days, increasing nausea and vomiting, constipation, and she was found to be hyponatremic in hospital. Her past medical history includes 2 grand mal seizures, for which she was started on carbamazepine. So her urine porphobilinogen was analysed, and this was found to be significantly elevated, more than 10 times the upper limit of normal at 16.8 micromoles per millimole creatinine. Her total urine porphyrins was also significantly increased. The second step was then to analyse the plasma porphyrins, and we identified a peak with a maximum emission at 627 nanometers, which is diagnostic for this condition. Because we had the fecal sample available as well, we did analyse the fecal porphyrins, and the total fecal porphyrins were significantly elevated, and the copper porphyrin 3:1 isomer ratio was greater than 1.4, which is also a feature of variegate porphyria, as well as hereditary copper porphyria. But the plasma peak was diagnostic, and this is a case of variegate porphyria. The cutaneous porphyrias can present with 2 different clinical presentations. The first is a bullous or blistering porphyria with skin fragility, and this occurs in Porphyria cutanea tarda, PCT, or the very rare congenital erythropoietic porphyria, CEP, or VP, or HCP. The second presentation is that of an acute, very painful photosensitivity upon exposure to sunlight, and this occurs in the 2 protoporphyrias, erythropoietic protoporphyria and X-linked erythropoietic protoporphyria. So why do these symptoms occur? Well, the porphyrins, due to their molecular structure, are photoreactive, and the excess porphyrins produced in the liver or the bone marrow, respectively, depending on the type of porphyria, circulates through the circulation and circulates through the skin. And as they circulate through the skin, they absorb visible light, and the molecules are excited. And this creates reactive oxygen species, which either directly damage proteins, lipids, and nucleic acids, or indirectly cause damage through the release of inflammatory mediators and inflammatory reactions. So the bullous porphyrias all have fragile skin, and they also develop vesicles or bullae, as you can see on the picture on the right-hand side. These bullae rupture and they crust, and it's characterized by slow healing with permanent scarring, which can lead to hyper or hypopigmentation. And they also develop these small white lesions called milia. The acute painful photoreaction in the acute photosensitivity porphyrias occur within seconds to minutes after exposure to sunlight. And this presents with an itching or tingling but also, if severe, there can be swelling and erythema. But often there's nothing to see on examination, and the diagnosis usually relies on the history. And often this leads to a delayed diagnosis. When there are repeated acute episodes, there can be some very subtle chronic changes. So Porphyria cutaneous tarda is the most common porphyria with an incidence of 1 in 25,000. And it's different to the other porphyrias as it commonly occurs as an acquired sporadic porphyria, although a minority of patients can have a familial PCT. And it predominantly occurs in males. PCT is due to inhibition of hepatic uroporphyrinogen decarboxylase. And the reduced hepatic urodeactivity is due to the production of an inhibitor, uroporphomethine, from iron-dependent oxidation of uroporphyrinogen. So iron is very central to the pathogenesis of PCT, and therefore PCT is associated with the following conditions: excessive alcohol use, prescribed estrogens, hepatitis C, HIV, and genetic hemochromatosis. Whilst definitive treatment is commenced, we advise patients to avoid sunlight, as the blisters in all the bullous porphyrias, the blisters occur only in the sun-exposed areas. So to avoid sunlight in the form of covering up, protective clothing, but patients can also use reflectant sunscreens, which I will explain further when we discuss EPP. We also address risk factors, such as the excessive alcohol intake or viral infections or iron overload. There's two definitive treatments, venesection or low-dose chloroquine, hydroxychloroquine, and both are equally effective, independent on the associated risk factors. But usually we reserve venesection for patients with iron overload and use medical management in the other patients for practical reasons, unless there's a contraindication of sorts. And then we monitor the patients until their urine porphyrins are normal, and we use the urine porphyrins to monitor for relapse, as most patients relapse unless the risk factor is entirely removed. The last porphyria we're going to discuss in more detail is erythropoietic protoporphyria. This is an autosomal recessive condition with a prevalence of 1 in 100,000 in Europe. And this occurs when the ferrochelatase activity is reduced to less than about 30%. Now, in the vast majority of patients, this enzyme reduction is due to the co-inheritance of a pathogenic mutation, a severe pathogenic mutation, and a common hypomorphic polymorphism in trans affecting splicing of the enzyme. The mean age of onset of symptoms are usually in the early toddler years, but due to the condition not being recognized, as there's usually not much to see when the skin is examined, we do see that patients are diagnosed generally later and often into adulthood. And the acute photosensitivity in this condition is due to the increased free protoporphyrin due to the reduced ferrochelatase activity. So upon exposure to sunlight, people start developing burning or tingling or stinging pain, which becomes very severe. And the exposure time varies between seconds to minutes, sometimes up to half an hour for some patients. They can experience itching, they can develop some redness, and if it's very severe, swelling and edema. And once this reaction has occurred and it's been severe, it lasts for hours to days. As mentioned before, if there's repeated acute episodes, then people can develop subtle chronic changes, which is a waxy thickening of the skin and some very subtle linear scarring. But usually there's not much to see on examination. History is the key. So the cornerstone of treatment is for patients to avoid sunlight, and this is by covering up with various modes of clothing, hats, sunglasses, long sleeves, etc. We also advise using a reflectant sunscreen, which is available on prescription, and this is sunscreens that contain zinc or titanium oxide, and therefore are pasty and not very easy to use often. Normal sunscreens, which have been designed to block UV light, is not effective in the cutaneous porphyrias. Sunscreens blocking visible light is what is required. Also, due to the lifelong avoidance of sunlight, patients are at risk of vitamin D deficiency and decreased bone mineral density, so we replace vitamin D. There's a therapy available, narrowband UVB phototherapy, which induces the skin to undergo photoadaptation. And this is helpful in many patients to prolong the period between exposure and when they develop the symptoms, which helps with quality of life. Some countries also have available an alpha melanocyte stimulating hormone analog, which promotes melanocyte-mediated skin pigmentation without UV exposure. Many patients with EPP have an associated mild microcytic hyperchromic anemia, but typically iron replacement does not help or does not respond to iron. In actual fact, iron stimulates erythropoiesis, which then increases Porphyria concentrations and worsens the skin sensitivity. EPP patients can develop liver complications as well. A minority of patients have abnormal liver functions and they can develop gallstones. And a very small minority can develop a very severe cholestatic liver disease picture, and this can unpredictably and very severely and quickly progress to fulminant liver failure. So our diagnostic approach in the lab is to initially, when there are active skin lesions, to analyze a plasma sample. If there's no fluorescent peak, then the skin problem is not due to porphyria, as in porphyria, to develop symptoms, you require increased amount of porphyrin circulating through the skin and reacting with sunlight. So if we find a peak and the peak's emission maximum is at a position greater than 623 nanometers, then it could be either VP or one of the protoporphyrias. What is then required is to analyze the red cell-free protoporphyrin, which is normal in variegate porphyria or not increased, but increased in the protoporphyrias. If the plasma fluorescent peak is less than 623 nanometers, then it could be either PCT, HCP, or CEP. And then fecal porphyrin differentiation by HPLC is required. In the exceptionally rare CEP, the copper porphyrin isomer 1 is significantly elevated in the feces. In HCP, the copro-3 isomer is significantly elevated, leading to an abnormal ratio, as mentioned before. And in PCT, additional porphyrin species, isocopper-porphyrin and other decarboxylated species are observed, which are not normally seen on HPLC. So to screen for cutaneous porphyria, the most appropriate sample is a plasma sample protected from light. So an example case. This is a 66-year-old male with a heavy alcohol use history and during the summer developed blisters and fragile skin. So the first step was to analyze the plasma porphyrins, and this showed an emission fluorescence peak at 619 nanometers. So we know this could be either PCT or CEP or HCP if we think about the diagnostic algorithm on the previous slide. So we analyzed his total fecal porphyrins, which were elevated at 274 nanomoles per gram dry weight. And HPLC fractionation showed multiple decarboxylated porphyrin species, including isocopper-porphyrin. We had a urine sample as well, and we analyzed the total urine, as this is very useful in monitoring patients, and this was also significantly elevated at 345 nanomoles per millimole creatinine. So this is a case of or an example of Porphyria cutanea tarda. In summary, the porphyrias are rare, but they are serious conditions. Acute attacks are potentially life-threatening, so think about it, especially when the patient is a young female who have presented with multiple presentations with unexplained abdominal pain, and especially if there's associated hyponatremia. And plasma EDTA sample is the most appropriate sample to screen for cutaneous porphyria, and a random urine sample is the most appropriate sample to screen for acute porphyria. And finally, seek expert information or advice. because these are rare conditions and people do not have experience with this condition or with any of these conditions really. So I've put a few links here that you might find useful. The first is a link to the European Porphyria network, who on their website there are very useful webinars on the different porphyrias for experts and non-experts. The second link is to the American Porphyria Foundation. And the last link I've referred to previously, this is for the Welsh Medicines Information Centre, where information on drug safety in the acute porphyrias can be found.